Hi, everybody, and welcome. Thank you for joining us for the third annual Penn Nursing Innovation Accelerator pitch event. My name is Antonia Villarreal, and I am the proud Dean of Penn Nursing. Penn Nursing is known for its leadership and commitment to innovation, and for embracing the true nature of nursing. I believe all nurses are natural innovators. We prove it every day, whether at the bedside, in our communities, in our research, in the boardroom, or in the halls of government. Being creative change makers is part of the job description of being a nurse, because we often see challenges from a different and more holistic lens than others. It is that lens that is at the heart of today's pitch event. The Innovation Accelerator Initiative is an exceptional opportunity for Penn Nursing students and faculty and their partners to develop new ideas, new solutions to challenges, and today is the day that we see the breadth and the depth of this creativity. The pitch event truly is one of my favorite events of the year. The past pitch opportunities have yielded devices that, when brought to scale, will make lives better. Dr. Pam Cashione's Smart Socks that assess signs of heart failure, and I think a few other things now. Stephanie Modry's wearable device that tracks postpartum hemorrhage. Brooke Goodspeed and Sarah Cronin's Stay Safe device for autism elopement. These innovations came not only from clinical practice, but also in caring for individuals in their own families. It isn't just about who can come up with the most unique idea, it's about who can come up with an idea that can be implemented and scaled to improve the healthcare and also transform health. I'll look forward to hearing the latest round of pitches for innovative solutions. This event and this initiative showcase the incredible ecosystem we have here at Penn and Penn Nursing. And there are many on this event, in particular our collaborators and also our board of advisors who have supported us and who have been on this journey with us. And I'm so grateful to have you with us. As always, some of our participants from this pitch event will receive funding for the creation and testing of their early stage solutions to health and healthcare greatest problems. These participants, chosen by a panel of esteemed judges who you'll meet with shortly, are from the greater innovation and entrepreneurship community, and they will prioritize solutions that serve populations. Importantly, our participants will have access to our advisors who have been helpful in thinking about next steps for some of our former winners. I want to extend my thanks to all of our judges for being here with us tonight, and again for your thoughtful comments. I want to emphasize that all participants are winners for developing their ideas, for having the courage to present them to what I am telling you is a friendly audience, and they in turn will receive invaluable feedback for the next steps. I want to thank faculty George Demiris, Marion Leary, and Terry Richmond from Penn Nursing, and Melissa Kelly from the Penn Center for Innovation who have spearheaded this effort. And of course, thanks to all of you who submitted applications. I want to thank our funders for this event who make this initiative possible. Carolyn and Thomas Bennett, Seth and Jane Gins, and Andy Laporte. And finally, thank you to our live sketch artist, as well as our keynote speaker, Hiyam Nadel. At today's pitch event, you may be seeing tomorrow's most daring and effective innovation in healthcare, and I congratulate everyone who submitted applications to the Innovation Accelerator and to those pitching your ideas today. I can't wait. And with that, I give you Marion Leary, our Penn Nursing Director of Penn Innovation and a former Geek of the Year.
Thank you, Dean Tony, so much for that introduction of our event. Hi, everyone. I'm Marion Leary. So I'm the Director of Innovation here at Penn Nursing. Welcome to our third annual Penn Nursing Innovation Accelerator event. I am so excited for you all to hear faculty and clinician pitches of their innovation ideas. We have 3 teams this year who will each have 6 minutes to pitch their problem and solution to our esteemed panel of judges, and then I will moderate 4 minutes of questions. While the teams are pitching, visual artist Rachel Acker from Health Hero will be live sketching the presentations, which will be displayed at the end. Our judges this year include Dr. Martine Sepulveda, a Penn Nursing Innovation Advisory Committee member, Lynda Benton, Senior Director of Johnson & Johnson, Brett Topche, Managing Director at Red and Blue Ventures, Jenn Hartt, Managing Director at Healthcare Investment Group within the Healthcare Investment Group at Ben Franklin Tech Partners, and Dr. Nalaka Gooneratne, the Associate Professor and Director of Penn Masters in Translational Research in the Entrepreneurial Science track. I want to thank you all for being here today and providing important feedback to our finalists. Once all of our teams have pitched, the judges and I will leave this virtual room to confer. While that's taking place, Hiyam Nadel, the Director of the Center for Innovation and Care at Massachusetts General Hospital, will give the keynote talk. Following her talk, we will announce the winner or winners of the Innovation Accelerator Pitch Competition. The winners will receive up to $10,000 to help develop and test their innovation, as well as go through a 10-month accelerator program offering mentorship and education from within the Penn Innovation and Ecosystem, as well as the greater innovation and ecosystem around the country. If you're interested in potentially mentoring our teams, please let me know. Last year, we awarded 2 winners who each went through our Innovation Accelerator program. These teams will now provide an overview of their work and experience over these last 10 months. What they've done in this short period of time during a continuing pandemic is truly impressive. I want to thank last year's mentors for all the work that they've done with our teams over this past month. And again, they couldn't have done it without the mentorship of those individuals. So if anybody's interested in getting more involved with our teams and our accelerator program, we'd be happy to have you. So like I said, we're going to have each of our teams from last year present their update of what they've worked on over this past year. First up will be Stephanie Modry, who will present their team's postpartum hemorrhage project. So Stephanie, if you want to come on video and we'll get started. Martine, are you able to turn your video off, please? Thank you.
Okay, can you see my video, Marion?
Yes, looking good.
Okay. Hi, everyone. My name is Stephanie Modry. Today I'm presenting on VasoWatch. Last year I won this with my partner Jim Weimer from the School of Engineering and Dr. Kim Trout from the School of Nursing. And we've made a lot of progress in the last year, so I'm so excited to report back. So what we are working on is an early detection of postpartum hemorrhage. The issue is that we have over 800 women a day dying in childbirth. 54 to 93% of the deaths are preventable, but postpartum hemorrhage is the #1 leading cause. Worldwide, there are 14 million postpartum hemorrhages that take place. And to give you some context, the issue is a difficult one to work with. For one, it's usually a visual estimation of the blood that is coming out. And we have learned through a lot of research, lots of published research, that our visual estimation of the blood is oftentimes wrong. And the more blood that there is, the even worse we are at estimating. And sometimes it's off by as much as 35%. Plus, the vital signs are often late indicators of what's happening to a mom. So we are looking for a closer, accurate, continuous monitoring of the mom's vital signs. And what we are doing is we are using basically a smartwatch technology with the little lights that shine underneath that go against your skin. That is called PPG, also known as photoplasmography. And Jim, I would say, is an expert in that. Dr. Weimer is an expert in it. And we're building upon research that he has done previously to help to alert about slow and insidious blood loss that is happening after a cardiac procedure. So we are taking this to see if we can actually capture it in a more robust kind of clinical scenario when action needs to take place very quickly. So we're using the lights to be able to assess the mom's capillaries and to give us an indication via an alerting system if her blood has been shunted away from the capillaries and more to her more important organs, such as her brain and her heart. So by giving this information sooner, the clinicians can act sooner, not using guesstimation on blood loss, but rather what's happening internally with her. And it could mean getting the right meds to her appropriately faster and possibly reducing other expensive and risky interventions such as blood transfusions and operative procedures. Oh, sorry about that. I'm just gonna go down like this, sorry. So in terms of like what's out there right now, their technology oftentimes exists in relation to assessing the fetal status and if mom is going into preterm labor, but there's no one assessing exactly what we are looking for right now. And interesting research that we found actually by a new Penn staff member when she did research out in California at Kaiser in a very large study. They found that when women were labeled as low, moderate, and high risk, it was not really helpful at all because 40% of those who had a postpartum hemorrhage were those who actually occurred in the low-risk women. So it's very hard to identify who will hemorrhage and who won't. In terms of some limitations of the other diagnostics that are out there, number one, we do have the option to do a quantitative blood loss in the clinic, in the room at the birth. It is a very burdensome process. It can take a long time, and then while you're doing it, you're trying to calculate it, you've lost time on when you could have been helping the mom. And a couple other companies that are trying to do some more with technology. And then some are looking at shock index, but that's relying on vital signs. And with the mother, her body has increased the blood volume in anticipation of some blood loss at birth, but we know that the vital signs are going to be a late information, a late indicator of if she has hemorrhaged or not. So by giving a continuous monitoring system, we're hoping to be able to give a more holistic picture to give more effective interventions. So we are also looking at this as a way to democratize care so that moms in low resource settings, moms in the global setting would be able to use our device in addition to moms in high resource hospitals. So we have an option for this to be able to expand over to a smartphone, which can be very helpful in, say, developing countries when you have a birth attendant, but she has limited resources, but because of 80% of the people in the world having a smartphone, it can help her to be able to help the mom better. And we are also helping to make the obstetrical team make better decisions faster. And what it can do is if a hemorrhage has happened and no one is in the room, it can also bring the staff to the mom faster, because once she goes to the postpartum unit, she is not continuously monitored like she would have been on the labor floor. So it's important to understand the context of this as well, is that in the US, the maternal mortality ratio is the highest among all industrialized nations, and we're actually double of the #2 country. We also have some areas where in the US, where if you have a city with, for example, in Washington, DC, their postpartum hemorrhage rate, their maternal mortality rate is actually double what the US average is, and it's a largely African American population. We also know that Black women are 3 to 5 times more likely to die than white women from a PPH, and overall, the maternal death rate for Black women is 2.5 times that of white women. So we're hoping with this device to be able to provide unbiased care to bring the clinician to the bedside to act quickly. To give a summary of our last year, this day, 365 days ago, we won the $10,000 prize, and our goal was to use that for our pilot study, for our proof of concept study. Along the way, we also were one of the 11 winners of the Penn Health Tech Award, and we started and completed our pilot study. We collected 525 patients in 13 weeks at Pennsylvania Hospital. We ran 24/7. I had 25 undergraduates and MPH students from Penn and Drexel under me. And we're actually continuing on with several of them who are going to be using our data to write papers for their master's thesis at Drexel. And we are anticipating between 8 to 10 clinical papers coming out of this, in addition to tech papers based upon the intellectual property that is being developed. So what's happening currently is Jim Weimer is furiously, maybe feverishly is a better word, working on the algorithm development. And then we are hoping to file our IP and publish our results. We have selected a CEO, but we are not going to officially hire her yet until we find out from the NIH if we have received a phase 1 grant, which will be pretty significant. We also have a few other grants in process. One is for 1.5 million, and we'll be applying for a J&J grant, and we are going to apply for another one as well, which is the NIH combined with the Bill and Melinda Gates Foundation. So we've got a number of things that are cooking, and we're moving in a good direction. Here is just that little summary. Of the 525 women who are in our study, we captured 184 postpartum hemorrhages, and that's according to the World Health Organization of a 500 milliliter blood loss or greater. And that is very, very significant. And even if we scale back to what the American College of Obstetricians and Gynecologists of what their rates are, which is 1,000 across the board, not 500, our rates were significantly higher than what the published data is right now for PPH. It could have been affected a little bit by the Delta, which was present this summer, and we did not anticipate that being around when we were doing our study. But we were able to catch a lot of data pretty quickly. And here are some demographics on our study. 35% PPH rate according to the WHO guidelines. We had more than 50 units of packed red blood cells that were given among our participants. Thankfully, no hysterectomies or deaths. And we have ranges going up to 2,500 milliliters for the blood loss. You can see the breakdown of our demographics, and it was fairly consistent across the board of breakdown between white, black, and unknown, and their occurrence of postpartum hemorrhage. And the unknown was based upon what was entered into EPIC. We went by that. So here's a picture of myself and Jim. And then here is our team that we've assembled over the year. We have Dr. Kim Trout, Martin Jose Sepulveda, Marie Marlowe, Det Anson, and Bhavna. Bhavna we work with on a very close basis. She's over at PCIV, the Penn Innovation Center. And she is a big help, especially with writing that large NIH grant. Marie gives us advice in regards to FDA, because ultimately we will want to go to the FDA. Det we'll be working with even more to develop our platform used for communicating back to the nurses from our device. And Martin has given us lots of advice in many different areas. So my last thing is that I just, in general, after being a nurse for 23 years, always being in obstetrics, I want to help women thrive after their birth, not just survive their birth. And it's been a wonderful year, and I really thank all the support that I have received from Penn. I have definitely learned a lot along the way. There's been some bumps, but my mode has always been to just keep going. I believe I can figure this out, and I usually have figured out every little problem that I come upon.
Great. Well, thank you, Stephanie, for your presentation. Really just phenomenal work over this past year.
Thank you. Thank you for your support.
All right, so next to discuss their progress with their innovation, Stay Safe, is Sarah Cronin, Brooke Goodspeed, and Kevin Thomas. You guys want to come on audio and video and take it away.
Okay, can everyone see this?
Yes, looks good. All right, Brooke, I will let you take it away.
Awesome. Thank you, everyone, for your time and attention today. My name is Brooke Goodspeed. I'm here as a member of the Stay Safe team, along with my colleagues Sarah Cronin and Kevin Thomas. And today I'm going to review our 2021 accomplishments since the Innovation Accelerator last year. So autism is a common condition that by most recent reports is seen in 1 of 44 children. We know that there is an increase in diagnosis every year, and autism is becoming something that most people are now very familiar with. What many people may not know, though, is that elopement is a challenge that is seen in up to half of people with autism, and this can really extend over the lifespan, although we will be talking primarily about elopement from the point of a child and for the points of this demonstration. Elopement's dangerous and often fatal. We know that 1 in 3 of these elopement events ends up being a fatality for a family. Losing a child can be perhaps one of the most devastating experiences to go through, and so we really are looking at this from a family systems point of view and approaching from a therapeutic intervention that could not only interfere with and stop an elopement from occurring, but really be a tool for teaching safety within the home. So our solution is to create a pair of bracelets that link caregiver to child so that elopement is identified at the moment at which it occurs. So Sarah, if you could just play this video. And when the child crosses the perimeter, an alarm will go off in both the child and caregiver bracelet. This stops the elopement and alarms the parent and the child of the behavior that was dangerous. And this is something that can happen instantaneous and prevent the fatal outcome or any excess death and disability.
And I just want to point out
that I'm going to pass this over to Sarah, who's going to go more in detail about our progress over the past year.
Oh yeah, I just want to point out this video is from our prototype video from our class with Marion. Actually, in spring 2020, we took the innovation class with her. So just some backup info for people who may not know that already. Okay, so these are our 2021 milestones, just a brief overview. Our goals are listed here. We wanted to establish ownership of our own innovation since we technically did begin in the class with Marion. We technically did fall under Penn's legal umbrella there, and then we wanted to found our LLC. We had a technical strategy and build out section that led to our proof of concept, which Kevin's going to go over. And then we did a lot of vendor and mentor relationship building, a lot of talking, and then we finally had our product survey. So to begin, establishing ownership actually took a lot longer than we thought it would. There was a lot of back and forth with the legal department, just they required more information, things like that. So we got our official ownership separate from Penn in April, on April 21st of the last year. And as soon as we got that, we went straight into launching off all our work. So we founded our LLC, we set Kevin on to coding, and this is kind of a general timeline of the year. So starting in the accelerator event until our proof of concept in December. But we did want to emphasize that you do run into different roadblocks and different setbacks that you really couldn't anticipate. You think you anticipate everything, but we just thought this was a fun thing to point out. And so we did finally found CGT Solutions, CGT for Cronin, Goodspeed, and Thomas LLC, which we're really excited about, and we're really proud of that. So next, I'm going to pass it to Kevin to talk about our technical.
So in 2021, once we got the green light to go ahead, we kind of sat down and did a tech assessment of what we wanted to use for our product. Tracking technologies can range from GPS camera to basically inverted home alarm systems as a solution to what we were solving. We actually settled on using an ultra-wideband solution. Caused a slight pivot in our tech in about the May to June area. I want to call out about what kind of went on during the year. Each technology kind of had price points, features we could get, features we didn't need, manufacturability, things like that. And we settled on, like I said, ultra wideband. From there, it was a game of moving into storyboarding and getting there. If you want to click next. So for our proof of concept, there's basically two sides to the equation. There is all the software, everything that runs in the cloud for the monitoring, and the parent app that runs. The other piece was the actual bracelet. For the app and cloud, that was simple. We built it all in-house, cloud-native solution. We were able to do it. We started coding that right away. The other piece of this was the hardware we're going to build, the slightly more complicated piece. There were three approaches we could have taken. We could have done it ourselves, cobbled it together. We could have hired a company to do it for us, or we could pay a third party for their existing kit. What we ended up doing was repurposing a third-party solution for enterprise tracking. This tracking is used, say, for tracking forklifts in a warehouse setting. It was built upon technology we're going to use in just a slightly different form factor. So what we did was we built the software out for about 4 months until we finally managed to find and procure said hardware. And then we put an abstraction layer over their software to connect it to our software. At the end of this, we had a working proof of concept with basically a fully formed parent-side app and a trackable device for a proof of concept that just wasn't quite in a bracelet form factor. Still able to attach it to yourself and move around and see that everything's working. And it served to validate our technology that our solution is going to work as long as we shrink it down and put it in a bracelet.
So I'm going to cover a lot of the soft stuff we did during the years. I like to say all the vendor and mentor relationship building. So the four main areas besides our mentor that we worked with during the accelerator was in legal, accounting, manufacturing, and design. So we were very fortunate in we were able to tap into our networks, and we found a pro bono legal consult that we could do with an IP lawyer. And they were really helpful because they also specialized in startups, so they could help us with our LLC setup, kind of talk through the different options, vesting schedules if we need them, ownership versus salary, how we want to bring on new people, is it worth it trying to bring on an intern right now, things like that, and if we would be eligible for IP down the line. So different conversations about that. That was extremely informative, frankly, and was very helpful over about mid-year, early to mid-year. Accounting, we were put in touch with through Marion for filing taxes, and manufacturing was another vendor we worked with since Kevin is an excellent engineer and Brooke and I are both great nurses, but we are not electrical engineers and we do not have a clean room. So we were talking about finding a vendor who could help us actually build the physical watch in a kind of clean lab. And we found one here in Philly who also has capabilities to outsource to manufacturing later down the line, which is great for when we want to scale up. And then lastly, we have a design consult. We talked to people about another person we got put in touch with about designing the actual bracelet itself once it was a little bit past the beta stage, maybe like the first round of a final product there. And so we'll bring them in later on once we are at that stage. So lastly, our product survey. Our product survey is probably the most informative part of this whole project. It started originally in Marion's class where we got that initial, oh, this is a real need that really hasn't been met by anyone in the autism community. And so we continued that product survey because we want to make sure we're making something that will actually appeal to people. So we wrote, proofread, and disseminated an initial survey at the end of the year. We got a third-party editor for it who actually specializes in product feedback. And we just got our first round of results back from that. And just to give an example of questions we asked them, we really were focused on target population, need, and interest, any areas of pricing. We had an idea of where people might want to what people may want to pay for things, and then again, preferred bracelet materials. So that was our summed up product survey. So goals for 2022 going into 2023, we're really excited to move from proof of concept to a beta product. Our team calls it a potato on a string product, which is with Kevin. It needs to be in the beauty salon a little bit, but we know it works, it functions, and so we can go ahead and move on into kind of making it smaller and really, really defining those perimeters that we set originally. We're excited to expand on the survey.
We want to confirm the design via surveys, maybe go into a little bit more conversation with people about the materials that their kids would really be open to accepting. Luckily, based on the proof of concept that Kevin has put together, we do have flexibility. Say if a child does not want a bracelet, they'd rather have something else, we can kind of work within that space to find the best solution. And we'll be doing that through surveys, and then launch into getting a real beta product going with that and ramping up our funding. So with that, that's our 2021 wrap up. And thank you, everyone.
Thank you. Stay safe, team. I know there's been a lot of roadblocks, but your persistence and ability to pivot has been a great thing to witness and just exemplifies the process of innovation. So good work all around.
And thank you to Marion, too. I wanted to say thank you, Marion, for taking my calls when I'm panicking.
That's what I'm here for. I also do want to thank again all the mentors who worked with both of these teams throughout the year. I know that they could not have done it without you. So I'm really just so thankful that you all were willing to give your time to our Innovation Accelerator teams. All right. And now I am so excited to begin our pitch event. So as a reminder, we have 3 teams who will be pitching. They will each have 6 minutes to pitch and then 4 minutes of feedback from our judges. So I am doing a little bit last minute shuffle. I hope our finalists were paying attention to the chat, because first up, I'd like to bring up Kira Foley, who is a Hillman Scholar in Nursing Innovation here at Penn Nursing, who will be presenting on her innovation In the Life, a social and dating app for LGBT elders. Kira, take it away.
All righty. All right, can everybody hear me and see my slides?
Yes, looks
Yes.
good.
Okay, great. I was going to say, I assume that's affirmative. All righty, so hello everybody. My name is Kira Foley and I am a PhD student and a Hillman Scholar in Nursing Innovation at Penn School of Nursing. And today I will be discussing a social and dating app for LGBT older adults that I am developing that's called In the Life. So over the summer of 2021, I was awarded a Design Thinking for Health grant from the Hillman Foundation to partner with LGBT older adults and brainstorm innovative ways to improve their health. In talking with this community, one theme came up over and over again. They wanted more opportunities to socialize, both in person and online. And I think this quote from one of my community partners, a 68-year-old lesbian, sums up the issue perfectly. She said, "Dating apps for younger people aren't an appropriate space for me, and dating apps for older people aren't a safe space for LGBT people. There is no online place for me." So based on this feedback, it was really easy to define a problem statement, which is LGBT elders desire an easier way to make friends, find community, and start romantic and sexual relationships. And we believe that a social and dating progressive web app designed specifically for LGBT elders can help address this problem. So LGBT elders are at a greatly increased risk of both social isolation and poor health outcomes when compared to heterosexual and cisgender elders. And this slide has all the numbers that you need to know about how LGBT elders are at an increased risk of social isolation and what the very serious health risks of that are. But I would like to tell you a quick story about the woman who was quoted earlier in this presentation, who we'll call Rose. So Rose was widowed 5 years ago and has been struggling to find community and companionship since. Her social circle is limited and is also aging, and she fears what will happen if she can no longer care for herself, as she's currently managing multiple health issues that seem to worsen every year. Fears she won't be able to find friends who understand her experiences as a gay woman if she has to move into a senior living community or a nursing home, or worse, she will be subjected to homophobia from her heterosexual peers. On LGBT dating apps, she hasn't been able to make connections with anyone her age, but on dating apps for older adults, she hasn't been able to find any women who love women. She's made some friends on online message boards, but she wants an opportunity to form deeper connections and to meet up with friends in person. She feels frustrated and scared for the future, and she just wants to be able to make friends and find a romantic companion as she ages. So unfortunately, Rose's story is not unique. I've heard it again and again from this community, and we hope that our progressive web app can improve both the health and quality of life for LGBT elders by reducing social isolation and loneliness. So our proposed solution is a 4-component social and dating app called In the Life. The 4 parts include a traditional dating app wherein users can match with other users and start messaging, a make friends component that functions in the same way as the dating app, but specifically for platonic connections, a message board divided by broad topics, wherein users can publicly chat about their interests in a safe space, and a calendar where users can post local events that might be of interest to other users, such as drag shows, book clubs, walking groups, pride events, etc. This is a small sample of available dating and social apps. This market is pretty saturated with LGBT dating apps and dating apps for older adults, but there's not one that is targeted specifically for LGBT older adults. In my market research, I found that most apps for LGBT people have 3% or less of users that are age 50 or older, and most apps for older adults have less than 2% of users who are seeking same-sex relationships. So this is a really untapped market in this space. Our app will be free to all members of this traditionally underserved and historically excluded community, but we will include some in-app purchases that can enhance user experiences to generate revenue. We will also partner with advertisers to generate revenue. Next steps for this project include application development and local beta testing, and then we will perform a pilot study to assess the app's usability and assess the app's health impacts. But in the next 5 years, we hope to achieve 10% market penetration, which would be about 300,000 users through partnership with national agencies that serve LGBT elders, such as AARP and SAGE. So this is just a cursory timeline that demonstrates our plans to expand from a local pilot study to a nationally available progressive web app. And this is our team. So our team includes myself, David Griffith, who's a social worker and community liaison, and he works with this population as the director of the LGBT Elder Initiative at William Way, which is a community-based agency that serves this population. A team of software developers and creative designers that are led by Det Anson, who is the president and founder of Brick Simple LLC, and my academic mentors, Dr. Jose Bauermeister and Dr. Nancy Hodgson, who are respectively experts in LGBT health and gerontology, and both of them have successfully used technology to improve health outcomes before. We are requesting financial support to complete the software development and creative design of our progressive web app to be utilized both through web browsers and on multiple mobile interfaces, statistical support for data analyses of the pilot study, and support for publishing the app on Google Play and in the Apple App Store. So in conclusion, I feel really passionately about improving the health and wellness of this population. I hope to give back to my elders, who are the individuals who so bravely fought for and secured my rights. I believe this progressive web app is an innovative solution to help improve this population's health and wellness. And thank you.
All right, thank you, Kira, for that really nice presentation. So I'm now going to ask our judges to come on and turn their video on, and we're going to take 4 minutes of questions. Great. Martine, if you're able to join, please turn your video on as well. All right, so I'm going to let you all just jump right in. Who has a question first?
Marion, it's Lynda. I do have a question. Great presentation. And question on your team. Looks like you've got a pretty young panel that's supporting you on this endeavor. How are you really ensuring that you're tapping into the elderly LGBT community to make sure that what you're putting together is what they need?
Perfect. That's a great question. So I actually plan on, before we finalize like the app, I'm going to bring the mock-ups to actual clients at the LGBT Elder Initiative. and have them take a look. So I'm pretty close with this community through that agency, but also through, I used to work at Babashi, which is another community agency that serves this population. So I'll also bring the mock-ups to them as well to make sure that it looks like something that they'd be comfortable using, that it's an interface that makes sense to them, that's legible, and that would be useful, that they find all the features useful.
Okay. Thank you.
No problem.
I have a related question for you, Kira. We described the problem as this population not being well served by what's out there today, but even within this over 65 LGBTQ population, there's a lot of segmentation, and there are even a couple of generations, and then there are differences in approaches to dating within it. It's also a complex time of life where loneliness and outreach might also be associated with declines in mobility or all the other problems of aging. So have you thought about an approach to beginning to do some segmentation analysis? And just a comment before you answer that. I do think that somebody could really do super well to specialize in this area. But I do think probably some ancillary additional thinking about really specializing in that area is important, because these other dating apps, they definitely target advertising. If I do a search, they may come up as having a segmentation for LGBTQA target audiences, even though they're not LGBTQA dating apps. They still want to be able to be a place for them to go. So there's an opportunity to really define serving the community more deeply.
Right. Yeah. So I think this is something that I think about a lot in working with this population. So of course, like the needs of like oldest old are very different than the needs of someone who's 65 years old. You know, when you're looking at a 90-year-old versus a 65-year-old, the way that their lives will be quite different. So I do plan to study in that pilot study, like segment it by age to see what the effects are in different age groups, and then also to get some feedback about if there's any features that would be useful to people in different age groups that might enhance their experience. But in this stage at this moment, I haven't figured out different ways to configure the app for the different age groups yet. I think I'm just waiting for some more community feedback.
Okay. We have time for one more question.
This is Martine, and I'd like to build a little bit upon the great observations that Jenn just made about aspects of intersectionality in LGBTQI plus seniors. A couple of other aspects of that are digital literacy, which will vary by socioeconomic status and a variety of other factors. How are you thinking about, and perhaps this is a TBD, so it may be an unfair question because you're early in the process, and so maybe it's a question of ensuring that, like the things that Jenn said, these things are on your radar screen so that you build them into your design thinking approach to this, and you've got those insights to help guide you so that we don't end up with something that has disparate effects on different intersectional subpopulations.
Yeah, so absolutely. There's varying levels of digital literacy, like in any group of older adults. One thing about LGBT older adults that's been studied or has been proven through studies is that they actually do have higher digital literacy on a whole, like across all SES like subgroups than cisgender and heterosexual older adults, that they're more likely to utilize technology, especially to make social connections. So that's an encouraging piece of data that we are working with a group that is already trying to utilize technology to make social connections. But yeah, when thinking about how maybe someone from a lower economic strata is interacting with technology, that might be different. So it's something that we want to bear in mind. And I think we want it available on computers. So, you know, if there's someone who uses the library or like uses a public space to utilize technology, they'll be able to do so. But then for people who have their own computers or people who have their own tablets or smartphones, they'll be able to utilize it as well, which is why we wanted to move to a progressive web app model. So that, you know, people who utilize technology from different locations will be able to access this.
Great. Thank you, Kira, for your responses. Thank you to the judges for your questions. I'm going to have you all go back off of audio and video, and we're going to bring up the next team. Also, finalists who are pitching, make sure you check the event chat because you're getting some good comments in there as well. All right, so I'm going to next present or ask to come on audio and video is Sophia Carreno, who will be presenting Food for Health. Sophia is a nursing professional development specialist for community engagement at the Hospital University of Pennsylvania. Sophia, it's all you.
Thank you, Marion. Can you hear me and see my slides?
I can see your slides, though. You want to just put them in presenter mode.
Oh.
There we go. To the left, from beginning. Keep going. There you go.
All right. Hi, everyone. The U.S. spends nearly twice as much on healthcare than any other developed country, yet our outcomes are much worse. 75% of poor health outcomes are related to food insecurity, to social determinants of health, like food insecurity, meaning not having access to enough food to stay healthy. This means people are sick and dying, not because of their diagnosis, but because of poverty. Our program aims to fix this by using trusted lay people called community health workers and nursing students to address the root cause of food insecurity and help women obtain resources for a healthy pregnancy, live birth, and long-term stability. Meet Michelle. She makes $31,000 a year and is the sole earner for her family of 3. They live paycheck to paycheck, oftentimes having to choose between rent or food or medication. She's now pregnant and hasn't been gaining weight, and the fetus hasn't been growing normally. Her doctor knows she and her baby are predisposed to serious complications, likely due to food insecurity, and when asked if she has enough food, Michelle replies, "I don't need that kind of help. We get by just fine." Our data show, and as experts in this space, we know that Michelle is likely reluctant to disclose because she feels embarrassed about her situation. This is a problem nationally and at HUP. We have food insecure patients here. Healthcare workers ask the right questions and the discussion stops there. Michelle's story represents a big problem in this country. 23% of Americans are food insecure. Michelle is at risk for problems like anemia, low birth weight of her baby, and intensive care nursery stays. We know that Black households are 2.5 times more likely to be impacted by food insecurity, and Black women are at least 3 times more likely to die from pregnancy-related complications than white women. Michelle's story represents a big problem in this country. 23% of Americans are food insecure. Michelle is at risk for problems like anemia, low birth weight of her baby, and intensive care nursery stays. We know that Black households are 2.5 times more likely to be impacted by food insecurity, and that Black women are at least 3 times more likely to die from pregnancy-related complications than white women. This is the highest mortality rate than any other developed country. Our research shows that patients are twice as likely to disclose food insecurity to a community health worker than a medical professional. This is a very costly problem, $28 billion problem. Food insecurity and suboptimal nutrition, coupled with the stress that comes along with it, are at the root cause of this problem. We're confident that this can be addressed using our novel approach of early intervention and remediation of food insecurity for pregnant women. The constant in our solution is a community health worker. Again, someone who's deeply embedded in the community. They live, work, and worship in the community and understand the population well. The secondary benefit of this is exposing our nursing students to aspects of patient care that they would not otherwise see in a traditional nursing program or clinical rotation. The recent Future of Nursing report calls on us to change the way that we deliver care, and that nursing students are best positioned to properly address these health inequities like food insecurity, and this is what our program will do. So here's our program. Traditionally, women have limited visits throughout their pregnancy. They may or may not have complicated stays. Maybe they follow up with their postpartum appointment and then we lose track of them. Our enhanced approach looks beyond the medical needs. This includes frequent interactions, home visits, text messaging, phone or video calls, assistance with filling out applications, identifying other resources in their community that are available to them well after the baby is born. Especially, this integrates the community health worker as a critical member of the healthcare team, using the evidence-based impact model to provide social support, navigation, coaching, and advocacy for their patients. In our model, nursing students will be mentored by the community health worker and aid and support to ensure the patient's success. So what have we done so far? As you can see on the left here, the community health workers we know are successful. Through the 3 randomized control studies, they have shown significant results: cost and reduction, increase in access, and quality of care. We've established a food pantry here at Hub. We've built relationships with multiple community partners like Philabundance, who has agreed to supply us with food at no cost. And we have executive support from the hospital, university, and community health worker leadership. We know of 3 health systems right now that are tackling food insecurity in our region, and none of them are leveraging community health workers and nursing students and focus on the maternal population. These programs have difficulty associating return on investments and outcomes. Our program aims to make this impact and show the measurable impact through our program. We're asking for money to get this program off the ground. We would like to start small with a selective population of pregnant women to test our model and to plan to iterate on this design to ensure the success and effectiveness if we expand. The beneficiaries are the patients, payers, nursing schools, students, and hospitals. And considerations for revenue streams include partnering with payers who have vested interest in cost savings and the development of sellable training models focused on the community health worker-student relationship, as well as other population health principles. Here is our team. We know that the innovations like these are our only true hope for flipping the script on healthcare costs, preparing our nursing force for the future, and most importantly, equipping patients with long-term solutions for food security. We're asking you to rethink what innovation means and invest in our model, because we know that we would be able to, 1, cut costs, 2, improve care, and 3, answer the future of nursing call by changing the way we provide care. Michelle's baby was born prematurely and had an extended preventable hospital stay because of food insecurity. With improved nutrition, we can change the course of pregnancies like Michelle's, but only if we innovate together. Thank you for your time and attention.
All right, thank you so much, Sophia, for that presentation. I am going to ask our judges to please come back on video, and we will take 4 minutes of questions. Whoever would like to go first.
Marion, it's Lynda. I'll jump in again. So Sophia, congratulations on a great concept. I love how you're tapping into the Future of Nursing report and the work that's happening there, and the importance of getting, I think, nursing students experience in patient care outside of the typical bedside in the acute care facility. So love that. One of the questions I have, if you're pairing up nursing students with community health workers, who is providing oversight to the curriculum the nursing students are experiencing?
That's a great question. So we do have a team of folks that are involved in this program. As you can see, there are a lot of different partners in the Penn Nursing program. We have a partnership with a group of students that are already invested in this and an interest in working with us. So the instructors would be a big piece of that. The community health instructors are a partner with Penn Nursing. And also we have partnership with the community health leadership, as we'd said, and that would be a piece of this oversight as well.
Thank you.
Other questions?
Yeah, So I'm trying to better understand what is in the control of the program that can help in these interventions. You mentioned helping with completion of applications. Is this, for example, to make sure people know what's accessible through WIC and other such programs? And how scalable this is? Like, does it require a very hands-on approach? Would it be that nursing students at other institutions or elsewhere in different models, different regions or cities would likewise be able to do this? Or is it more to be and stay local? So that, if you can answer those couple of questions. I had a couple more, but let's just start there.
Yes, and this is meant to be scalable. We mentioned at the end that we're starting small because it is also such a big collaborative program. So we have partnered with, as I mentioned, Philabundance, which the operational piece is also part of the background of this program. We have established in the last 2 years and done a lot of research on what other hospitals are doing. And we, more than anything, realize that it's really, it can be very regional and specific to the institution. So we've been lucky enough to have the partners in place to see how this can be sustainable and work with those partners, including the patient that we've received buy-in from Women's Health and the Dickens Center. We have a few of our other teammates on the call as well. To be able to fully address and ensure that this is going to be something that is applicable, whatever, and how that the end user will know that this is going to help them with those, could be as simple as applying for WIC and having someone that additional support in filling out those applications.
Sophia, this is Jessie, by the way. I'm one of the team members. One of the things that we have, one of the problems with a lot of the food insecurity work is people give food to people and it's kind of a temporary fix. So what the community health workers have shown is actually helping provide people the food, yes, as a kind of stopgap, but then also setting them up with programs so that they're successful throughout. So the traditional community health worker program at Penn sets a time limit, but there are different programs throughout the country that use community health workers, which are, lay people from the community who are invested in health. So it could be scaled outside of this women's health population, but also scaled outside of the Philadelphia region, wherever anybody kind of has food insecurity and likely other social determinants of health.
Mm-hmm. Yeah, great. And so is the model to be a for-profit or nonprofit? Since you could get grants and other such partnerships that way as a nonprofit.
I think we're figuring that out.
Okay.
As the honest question, I think we're figuring that out, whether it would be nonprofit grant or whether it's profit, recognizing the cost benefit associated with the better outcomes.
Great. Okay. Thank you all very much. Time is up for the question portion of this. All right, and so our final presentation is from Jessica Abney, who is a junior here at Penn Nursing, and Julia Dunn, a senior in the School of Engineering and Applied Sciences. This team will be pitching their idea for a smart swaddle. So Jessica, take it away. And if everybody can go turn their videos off who's not presenting, thanks.
Can you see me in full screen?
Yes.
Okay, we're ready then.
All right, go ahead.
Okay, so imagine your infant is screaming and crying and you don't have the hands to pick them up and comfort them. Well, Chrysalis has a solution for you. Neonatal abstinence syndrome infants go through even more distress and crying and need more comfort from nurses or parents because they're going through withdrawal. Their parents took opioids while they're in the womb, and now they are essentially addicted to drugs. Neonatal abstinence syndrome has been increasing from 2010, and there's also a shortage of nurses projected to increase more by 2030 so they have less one-on-one care. Hospitals are trying to move away from pharmaceutical treatment for neonatal abstinence syndrome to an eat, sleep, console model. This model helps decrease the length of stay, morphine treatment, and cost per patient. However, this model is very time-consuming for nurses to document, so they often have not been able to implement it into hospitals yet. Chrysalis has an app design system that helps the nurses document with Eat, Sleep, Console, so they're not wasting time and could spend more with the infants. Since neonatal abstinence syndrome is on the rise and there's more nursing shortage, there is no product available that's alleviating neonatal abstinence syndrome without pharmaceuticals on the market so far. Our solution is a smart swaddle system. A swaddle essentially wraps the limbs of the baby to simulate a womb-like stimulation, and this comforts the infant.
Chrysalis is waterproof and electrically insulating for infant safety. A flap that goes over the chest contains the sleeve with all of the device's electrical components, such as a heart rate monitor to detect if the infant's waking up, 20 vibrational motors that provide the soothing treatments, and an iPhone app that allows nurses to remotely control vibrations and document ESC vitals through a Wi-Fi connection between app and swaddle. This is our swaddle and a mock-up of our app. You can monitor multiple infants at once, and when you click on one, you can see all of the infant's vitals, control vibrational patterns, and look at previous ESC evaluation documents. There are other sleep sacks and bassinets that also aim to comfort infants, but our product is the only one to incorporate an iPhone app and directly targets the NAS population. The overall market size for NAS is about $600 million, a third of which, and growing, is non-pharmacological care. We estimate a $65 million market share for Chrysalis. So far, we have successfully implemented both vibrational sequences in the vibration motors. We have a physical swaddle that we have integrated with our circuits and code, and one working app page that can remotely control the vibrations. By March, our app will be fully developed and we will have transitioned from an electrical sleeve to e-textiles, which integrates circuitry directly into the fabric and will make our product less bulky. We're also going to start some non-clinical testing using parent consent forms. From March to December, we would like to do more extensive device and app testing, especially through clinical testing and IRB approval, and we would like to seek FDA approval of our device through a 510(k) pathway.
Our projected revenue for this product will be through swaddle purchasing. This can mainly be through hospitals and outpatient centers that are dealing with neonatal abstinence syndrome infants. But we could also sell the product to parents because the swaddle can also comfort infants and newborns who are not experiencing neonatal abstinence syndrome. We also have app licensing revenue and partnerships, which could be from medical device companies, hospitals, or app purchasing groups such as Apple that would want to buy our app and help hospitals integrate it into their documentation system. The budget we are asking for is $10,000. We could get IRB approval free from Penn, and we've already had $600 from the Bio Senior Design Project. As we mentioned before, we want to integrate the electronic component directly into the sack swaddle so that it's not as bulky with the sleeve. That would be about $200 per unit, and we would make around 10 units so we could do some testing. We have app development and submission to App Store at about $1,000, and labor costs, including sewing and electronic components, $5,500, and a utility patent for the Smart Swaddle device, about $1,500. In the future, we are thinking about if we get more funding beyond the $10,000 to go more into clinical testing so we could get this product on the market hopefully by the end of the year. And our team is very passionate about helping nurses and infants struggling with neonatal abstinence syndrome be more comforted in a safer environment. Our team consists of me, a Penn Nursing student, and 4 bioengineers. Any questions?
Great, thank you both for that really lovely presentation. I'm going to ask our judges to come back online and get the question portion started. And I'm just going to ask.
Sure, I'll start. I'd like to better understand the cost side of things. So what do you anticipate this product ultimately costing, whether it's the parents, the hospitals, the insurance company, whoever is paying for it? And do you have any sense for what your cost of goods is at this point?
Yeah, so right now, what we would be selling for the hospitals without the electronical fibers in it is the swaddles with the sleeve in the corner, so we could put the little electronical slip in, so they could buy multiple of the swaddle devices, which could range from about like $15 to $20, because as everyone knows, infants could throw up, get bowels on it, so you could wash them multiple times a day and just take the electronical component out. And the electronical component would go from around 50 to 100 once we can make them in bulk.
And what does that leave you? How much does it cost you to make the electronic component?
Julia?
Yeah, I can speak on this a little bit. The way that we currently have our device set up, we've been able to get pretty much all of our components from the bioengineering lab. We did buy we bought a heart rate monitor, and it's currently powered by 9-volt batteries. So the way we have it now, it can be made pretty inexpensively. But looking into e-textiles, which we're starting to work on this semester, one packet of e-textiles, I believe, costs around $30. So we'll need one of those for each of the swaddles. So that will make it a little bit more expensive.
Hi, this is Nalaka. I think it's a really fascinating concept. And I think the ability to monitor vital signs is really quite helpful, because that can take up a fair amount of nursing staff time, of course. And so that, any way that you can reduce labor requirements is always a productive aspect. There's a lot of other vitals that can also be included, such as oximetry, et cetera. Have you thought about any of those other measures as well?
Yeah, we were thinking about doing other vitals, such as pulse ox, like you mentioned. And that would be moving forward hopefully with the e-textiles, what we could get coded for that. So that would be with the funding going forward.
And a related question, have you started to look at what's out there in the way of wearables that may be trying to push and pull information into the electronic health record? Because ultimately, vitals in the hospital setting, at least, would probably be something that needs to integrate.
Yeah, so currently products out there on the market do not aren't connected to an app specifically, like Chrysalis. So what our product essentially is doing is the device itself is taking the heart monitor, for example, and monitoring the cries, and then that information transfers to the app, which the hospital would pair with their system. For example, Penn uses Epic documentation, so the app could pair with Epic documentation after going through their HIPAA, and then it would automatically show up on a new column in the nursing documentation sheet. And other products out there, like I mentioned, don't have a connection app that is going through that extra process to gather.
Is that part of your nearer term development plan, to be sure that your app can push and pull information into Epic?
Yes.
Okay.
So we were planning on looking at that, hopefully going into March 2022.
Okay. 2022. Got it.
We have time for one more quick question.
Let me ask, if I can you share with us how you're thinking about evaluating the safety of Chrysalis on things like restrictive motion, on ventilatory efforts, on leakage problems from the devices that are installed, and so forth?
Yes, so essentially it wouldn't be restrictive because a swaddle is manually done. So it's kind of how we showed in the picture. It kind of looks like a little winged blanket. So the infant goes in there, and then either a nurse or parent would physically wrap them like they would any swaddle. So that really determines on how well the person wraps the infant. And in regards to any leakage, that right now the sleeve is in the electronical sleeve is in a waterproof component, so nothing would ever leak into the protective layer that's touching the infant. And when we move into e-textiles, that also would not be an issue because of the protective layer.
Yeah,
Great.
just to also add a little bit to the, is that fine?
Real quick, real quick.
Okay, yeah, I was just going to say the flaps on our swaddle currently only go over the infant's chest, which allows for like mobility in the infant's legs, which like from our research was really important in a lot of other swaddle designs, and we really wanted to incorporate as well.
All right, well, thank you. Thank you all for all of your incredible innovation ideas and pitches. We're gonna wrap up this portion, and I'm gonna ask the judges if you will please exit this Blue Jeans event and use the Zoom link provided to you in an earlier email to begin the review of the pitches. I'll join you there shortly. Before I head over, I want to introduce my colleague, Dr. Terry Richmond, who is the Associate Dean for Research and Innovation at Penn Nursing. And Dr. Richmond is going to introduce our keynote speaker, my friend and colleague, Hiyam Nadel. Dr. Richmond?
Hi. So Julia, turn your video and audio off. So hi, everybody. I am absolutely I love this event, and I'm absolutely thrilled to introduce our keynote speaker. So Hiyam Nadel is the director of the Center of Innovations in Care Delivery at the Massachusetts General Hospital. She's a founding member of the Society of Neuroscientists, Innovators, Entrepreneurs, and Leaders, otherwise known as SONCIAL, and a Johnson & Johnson Innovation Fellow. Delightful to talk with. I can't wait to hear her talk. I had a chance to meet with him earlier today. In her role as director of the Center for Innovations in Care Delivery at Mass General, she's both a mentor and an incubator of ideas for frontline caregivers, from conceiving an idea to prototyping and beyond. She has a long previous history prior to this role in innovation, and I'm not going to take the time to explain that because we really all just want to hear her. I'll finish by saying in 2020, she was recognized as one of the Extraordinary Women Advancing Healthcare Award from the Commonwealth Institute. This award recognizes 10 remarkable women in Massachusetts who are emerging and inspiring leaders, pioneering advances across healthcare, and who demonstrate collaborations, mentor others, and encourage diversity. She is absolutely fabulous. So I'm turning this over to Hiyam. And Hiyam, turn yourself on and we'll get going.
Thank you, Dr. Richmond. Can everybody hear me? Just nod.
Yes.
I have to say, I've met with the faculty today. I've met with some of the nurses at Penn Medicine, and I'm listening to these pitches, and all I can say is, wow, and I am honored, really, to be here to talk to you today.
Tell me how you ended up in innovation.
Well, so early on as a student, I was inventing and realized, of course, I didn't know it at the time. And when my nurse colleagues would call me up and say, is that your product on the market? And that happened about 3 times. And then I decided that that we really need to get to know more about what we're doing as nurses, because I would look around and see the same thing happen with my colleagues. And so it became a passion for me to really think about and help nurses, first of all, identify themselves as a natural innovator, and then get their ideas and move them forward. And so that's how it all started.
And look where you are today.
Yes. So what I thought I would do, and some of this may be repetitive to some of you, but I think it's a good idea to set the stage by defining what we mean by innovation, what we mean by innovation methodology. I would like us to discuss why we meaning frontline caregivers in particular, and nursing students, etc., to really be innovating. And I think looking at what is happening in our industry will give us that insight. Also, I want to talk about how we are trying to upskill frontline caregivers And I think what you're doing here at UPenn is tremendous, because I'm having to start from point zero with frontline caregivers as we're trying to educate them around innovation. Also, I'll talk a little bit about what we're forging with external partnerships, what we're trying to do next, and then some key takeaways from all this learning. So all of us in particular who are magnet hospitals, generally we go by this definition, which is the application of creativity or problem solving that results in a widely adopted strategy, product, service that meets a need in a new and different way. Innovations hopefully are about improvement in quality for patients, cost effectiveness, and efficiency. But I also would like to add that it can't be a burden to frontline caregivers. We've all heard how administratively burdened we are with documentation, etc. And although it involves lots of creativity, we also have to learn risk-taking, we have to learn how to pivot, and we always should be using human-centered design. And so I always tell everybody about Marion's course here. I think it's really one of the best. And so again, you are very lucky to start with this. And so design thinking really is just having some framework to generate innovative solutions through creative problem solving. And I always like to add gap analysis, meaning I have a solution A and a solution D, but there's a gap, so there's nothing in between that. And so sometimes that's how we figure out that there's something missing. And when we talk about human-centered design, I always ask, who are you innovating for? And we have to take that perspective, whether it's a patient, or it could be the health system, or it could be the clinicians. We're always really trying to live their life, trying to understand things from their perspective. And then we define and redefine the right problem. Now, this is very, very important, because if we don't have the right problem, we can't ideate and come up with the right solution. And that's what we learn time and time again. So we really try to, have people internalize this process and always utilize it as they move forward. So just looking at it from a graph, why do we care about innovation? So many of us in the past have always done the same thing over and over again. We might tweak it, but this graph shows the impact of real innovation, the way we can achieve true transformation. And I just like this graph because it just gives you a visual. So why should we innovate? I can tell you that we all believe that the status quo for us is no longer an option. And I always like to tell the story of Blockbuster Video and Netflix. For those of you that remember Blockbuster Video, and for those of you that don't remember Blockbuster Video, you'll understand in a moment. So Blockbuster Video was a brick and mortar store where you would go and you would pick up videos for the weekend or whenever to watch movies. You'd make popcorn and sit and watch all these movies. So Netflix came along and said, let's challenge this. Why do people have to go to a store to get movies? What if we deliver the movies to them? And that's how Netflix started. And again, so Blockbuster's response to that was more of the same, just build out more Blockbuster Video stores. And now with streaming, of course, this is what happened. Netflix is still here and Blockbuster is no longer. So the point is there is significant value. A significant value is appreciated from really questioning our assumptions and the status quo. So let's look at what's happening in our own industry. It's being redefined. Okay, there are new entrants, seen and unseen, that will give us a competitive landscape. So we can't be sitting on our laurels and not trying to do something about that. And not that this is all bad, but that we should be aware of this. Also, care models are being disrupted. These are innovation-based models, like the Minute Clinic. You don't have to go into the hospital or the doctor's office. You can just go to a CVS perhaps and get a throat culture. These take care to the patient. They become more affordable and more human, as redefining what patients, experience is with the healthcare system. So we defined what innovation is. We now know, we really should be involved as clinicians and as frontline carers, as academics. So how do we go about this? So I went to my chief nurse and said, is there a way that we can just try to elicit some of these ideas from the front line, see what comes up? She thought about it and luckily she found some philanthropy money, and we started what was called the Idea Awards. And so what we did first is really just put out an email, a call, and saying, if you have any innovative ideas, please let us know. Here's the application. We didn't put any parameters around it. We wanted to really hear from the front line. We wanted to understand what their baseline knowledge was of innovation. We also wanted some insight into the pain points they were experiencing. So this happened before the pandemic. We have 8 projects in the queue, and I will go over just an example of some of these. And some of the ideas that were coming where I would say weren't completely innovative, but we wanted to start somewhere. So the example I'm about to tell you is really around upskilling. The people that you see to the right are the staff from the medical intensive care unit, and to the left is the neonatal intensive care unit. So we borrowed a system engineering from manufacturing plants, and it was a very simple flip chart, and I know many institutions are using this. And so we would flip this chart for every day or every week that we had a CLABSI-free day or week. And so we're happy to report that the MICU has had 32 weeks of no central line infections. And then they had one. And so the staff was really devastated, because they would meet during rounds and they would talk about every patient had a central line. Why do they need the central line? When can it come out, etc. And then at the end of the week, they would get together, play the Rocky music, and then flip the chart for every week that was without an infection. And so I said to them, okay, well, let's look. What happened here? And so the infections that they were still seeing were from transfer patients. And so we had an aha moment, right? So if we inserted the central line, then now we need to pivot and treat the patients that are coming to us and being transferred differently. And so this is all good, okay? Because we are peeling back the onion, as we say. We're opening the doors for people to think differently, and now we have a different system for transfer patients. On the left side with the neonatal staff, they did a tremendous amount of work. And so what the door we opened for them in upskilling is that they said, let us look at all the ways that we can, where bacteria is introduced into the different lines. We reached out to the tube companies and we said, would you like to collaborate with us? We have some ideas for the tubes. And so they created pretty much an essential completely closed system, and they were able to achieve quite a few days CLABSI-free. The next example that we'll show you is that for ALS patients, eventually they're unable to safely swallow and have a tube feeding placed. But at the same time, there's a lot of manual dexterity that has to happen in order for them to feed themselves, as you can see in these photos. But with ALS patients, that declines constantly. And so what happens is they have to rely, if they go home, they rely on a caregiver, or they get, have to go into a nursing home prematurely or be readmitted for nutritional deficiencies within the hospital system. And this team came up with adaptive adaptive equipment that would go onto their digits or their handcuffs as they decreased their, as they lost more and more of their hand movements and stuff. And so what we found too is that they were able to keep those patients home because they were able to feed themselves much longer and not have to rely on others. And this is just the way we were thinking about packaging it within the hospital so the staff could reach and get their own material. And then we go on. So for the, it is widely known that many neonatal intensive care unit babies do develop language development later on in life. And so, in our observations, we saw newer nurses that were very focused on their task and wouldn't speak to the patient, wouldn't speak to the baby, and more experienced nurses, as they were doing things to the baby, would be coddling and gooing and talking. And that's how babies develop their language. And also there was a lot of noise in the neonatal intensive care unit. And so this product that we've created was something that we could put on their head. Again, we haven't tested it yet, but we could record the patients, the parents' voices at the right decibel, right frequency, and attenuating a lot of the noise outside of that. So you see, things get, as you go from a process improvement, you start to, upskill the nurses and the frontline caregivers to think really and elevate what their solutions are. Okay, so I do want to talk about timing. During the pandemic, we were working on 2 of these products that I'm about to show you, but we weren't getting anywhere really. And then the pandemic hit and we quickly pivoted these two products during the pandemic. So Kim is in the pediatric intensive care unit and Ryan. And by the way, the physicians and other colleagues, the therapies and everybody is getting involved in all of this innovation with us. And it's really been very exciting. So Kim and Ryan are on the biothreats team. And so they would be completely from head to toe with PAPRs and the gowns. And then as they were drawing blood from a pediatric patient, and this is what was happening, they had to still transfer the blood from a syringe to a microtainer or to another syringe or to a blood gas tube. So while they were doing that, there was a risk of splash and needle. And so they created just a very simple shield that is already patent pending that would protect the caregiver while they did transfer the blood and into the vacutainers. We also took this down to the laboratory and they loved it too because they're always transferring specimens into tubes itself as they're studying it, etc. So this is another case use. The other simple thing that we pivoted was we looked at the way the test sites for COVID were testing people. This was in the first and second surge. They would have 2 employees, one doing the test, the other one standing there holding the bag. The inpatient nurses were getting, if they couldn't find another person or another nurse to collect the specimens, they were taping bags onto the doors, outside the doors in patient's room. And so this is another test site. This is a physician. The nurse practitioner was in the tent testing and he was helping her taking the specimen. And this was our first prototype. So we tested at multiple sites. And then we finally came up with the second prototype and where this would be really take the place of another person. We could draw multiple labs that were going to different labs and have multiple bags out. And then as we were observing the end users as they were doing this, suddenly they started to use it for glucometers, for their phone, which of course infection control completely loved. And so they're very simple. These aren't high tech, but they certainly were very impactful at the time. So sometimes when you're thinking about your solution, always have it on the back burner because the timing sometimes may not be right and be ready to pivot at that time. And this is just as we were producing the what we call the Grabber Lab. Okay, so during the pandemic, we really took, everybody was back at the front lines, including myself, and I really took time to pause and reflect. Although we loved getting all these ideas, there was only about 20 applications a year through the Idea Awards. And I always really felt that that we weren't getting to everybody and really to the front lines. So we teamed up with the Healthcare Transformation Lab. We also teamed up with the Harvard Business School because we really want to study this particular challenge that we're doing. And we wanted to democratize the entire process. So really, it was ideas over titles, and it would go out to all 8,000 employees. And we were hoping that it would be a fun way to infuse the culture with an innovation mindset and really highlight transformative ideas can come from anyone. And so the way the Etherdome Challenge works, and by the way, the Etherdome was the where the first anesthetic was given. So we thought it was really sort of a cool idea to name it that. But the first round was we would put it out to all 8,000 employees and say, look, what are your pain points, and give us your solution. So we lowered the barrier. It was very easy to put in their idea. The round two was we went back, and gave it back out to all 8,000 employees and said, okay, tell us what you think is the best ideas. So it really took all the control back to the front line, and it was amazing. And then round three was all the top 40 voted ideas were invited to submit a full application. And then round four, which we just had, was the award ceremony, where we gave 4 $10,000 awards. We haven't started yet because we had to take another pause. The reason we love this platform is, first of all, it was anonymous, so because we really wanted to hear from everybody, including the environmental service people. You watch them on the floors, and they're just standing there, and they're seeing and hearing all sorts of things. So we were really trying to get to everyone. We also wanted a lot of analytics. How high was the engagement? And a way to prioritize all the ideas. And we wanted our leadership to be able to go in and see things as they were coming together. We had a lot about, really getting them to think that they were innovation disruptors. We wanted them to inform us, transform, reform. We had these everywhere. We gave out incentives, and although they weren't very much, every time I was on the units, they just couldn't wait to get their pen, or they couldn't wait to get their Amazon gift card. And it was really seeing their faces, it was sort of a distraction and fun. And so at the time, we really worried whether people would partake in this. People were tired, they were burnt out, they were exhausted, we had capacity issues, higher acuity. But I was really happy to report that we went from 20 applications through the IDEA program to 225. We did give them parameters. We wanted to know more about capacity management, the growing complexity of the clinical environment, patient and care team communication, of course, and we always leave the other bucket if people had ideas that weren't included in these. And the reason we created these buckets is because it came from the front line. We said, they were telling us, look, it's so busy, and we keep getting more and more patients. We're putting people in the halls. We are, we're really, help us, they're becoming more acute, and help us learn about the disease processes and things like that. And this just shows you that people were really engaged. We had over 15,000 votes that came in, so really highly engaged, which we were very happy about. Some of the demographics that we were looking at, how many were nurses, how many were clerical, unit assistants, medical assistants, and we wanted to look at ethnic groups that we have the data, but we really need to look at that more closely. We learned that on average, tenure that people felt comfortable putting in was 11 years. So if they were on the job for 11 years, so this gives us some insight that perhaps we should, really engage our younger and less experienced nurses. Female, male, and this is what's lovely about the platform is all the things that we can look at. How many came from ambulatory and community centers versus inpatients. And so the things that we are going to study is how do we motivate innovation when innovating is really discretionary? Because Terry asked me today, how do you get people to do this when it's above and beyond their day job? And we're trying to learn all of that. And how do we elevate all the quality of ideas? So in other words, what are we going to do with all 221 ideas that didn't win? And how do we continue to respond and spur continued contribution? So more to come on that. So what's next? My experience when we stood up the COVID Innovation Center during the pandemic, we invited all of the community. There were design companies there were plumbers, and what it taught me, how powerful it was to have everyone come in and weigh in. I mean, a plumber that I still keep in contact with taught me more about, filtration than I've ever learned before. So it was really eye-opening. And the patients, we involve in patients, but we really want to really make this more robust and scale it. We're also doing innovation rounds where we are going to, staff are too busy, so I'm going to them and just, entering into their staff meetings or what we do huddles and just talking about what are your ideas? What would you like to do? We're doing a little bit of solution sprints, which means that I may go up to a unit during their staff meeting and saying, hey, let's just take 10 minutes. Let's focus on problems this week and maybe focus on different problems or solutions at the next meeting. We're also thinking about, I talked to a nurse from the emergency room this morning, and really, do we want to start doing department or specialty challenges? Because the emergency room, for example, has many, many challenges that we could help with. Just keeping an eye on the time. So external partnerships. So what we mean by this is we can't solve all our own problems. And so how do we identify a pain point that we have and then who our external partnership could be? And so we're trying to streamline the process for these outside collaborators because it's really burdensome to our hospital. And this is one example where we're partnering with Inspiron. It's a startup, and I do love startups because I think that we can have a lot to say and which direction they go with. And I think that's been very, very pleasing to both sides. And I'll just go, this is computer vision. This helps with patients, and what you see is de-identified data. You see the patient and the employee as a stick figure. So I can look on my phone and say, okay, what is my patient doing? I can get alerts. If I say, is this patient going too close to the edge of the bed? I want to know about this and be alerted at that time without a central alarm. So it's going right to the nurse's phone. And we're getting a lot of, data analytics from it too. And we're going to start the pilot actually next week. So we're excited about that. So some of the key takeaways, what we found is staff are actually really engaged and empowered. Staff are always telling me I would stay at the bedside if I can continue to innovate. It's really bringing a lot of joy and inspiration. They're using creativity. They're learning to take risks. They are respectfully challenging the status quo. They're learning that failures are opportunities. Timing is everything, or move the time if you can. Always learn from other industries. I think there's a lot to learn from other industries. Create the table, direct access to your users, be there, start somewhere and be patient. But I do want to just take a little bit of time to say, you can have a gazillion great ideas, but but my experience has been if you don't implement them properly, it's not going to work. So always keep that in mind. Funding, think about your innovation and tech transfer, which I heard a lot today. We're still looking for philanthropy. We're also looking for a bunch of grants, and we love venture groups, hopefully to do that. And everything we do in medicine at some point may have to be researched and studied. And I have to put a plug in for all the Nurse Hack for Health that Marion and I are involved, so please join. You would learn so much over a weekend. And as we're doing these more and more often, we're seeing more and more engineers join us, developers, designers, physicians. So it's been a really great experience. And when you're doing your human-centered design, we're always asking why. Why do we do this way? Why does it have to be? But I also want you to think about dreaming and always ask why not. With that, thank you. And we'll open it up to questions.
Wow, thank you so very much. Why don't you stop sharing slides? And we have a few minutes for questions, audience. So first, Hiyam, I have a million questions, but if people have questions, use the Q&A feature and I'll serve as your voice. And while you're thinking of your questions, what's the biggest failure? Like we always talk about successes and we always say it's okay to fail. Tell us about a failure. I'm sure you've had some.
Oh, many. Well, I can tell you personally too, and I think this is where human-centered design really meant a lot for me. I was doing high-risk OB, which is my specialty, and we counseled the patient and said, look, if you carry through this pregnancy, you have 50% chance of dying. And at the time, she came for a few visits and then stopped coming. And then I was sick over it because I didn't know what had happened. People were jumping to conclusions and saying, oh, well, just non-compliant patient, here we go. And until I sat with her and I said, I want to take care of you when she showed up at her next visit. What can we do? I want you to be healthy. We're going to get you through this pregnancy because she decided to carry through. And she said to me, I'm a single mom and I'm the main breadwinner and I can't leave my job. And so until we understood that, I waited for her after work, before work, and really designed the solution around her. So, being young and inexperienced, I've had many of those. Coming up with an elaborate nutritional plan for a diabetic who had food insecurity but didn't realize that. And when we do innovation, we really try to control the failure so that the staff learns from it.
Good. I'm glad I'm not the only one who fails. So our judges aren't back yet, so I'm going to ask another question. So one of our audience members said, are people concerned when submitting their ideas, then knowing it'll be viewed by 8,000 people, that somebody may actually steal their idea?
No, and I think people ask me all the time. And so what we do is anything I show or anything has been already protected through patents. And I didn't show a lot of the other things that we've been working on because that hasn't happened. So that's why it's really important to work with your tech transfer office or innovation office, because they'll walk you through that. You apply for provisional patents, you trademark, you do all of that. And so you're protected. Now, I don't know what that means to show to 8,000 people. You have to be careful when you take it outside of your institution.
But how about the initial idea, Hiyam? So, for example, when the 225 ideas, right, that got voted by 15,000 people, they're not proposing the solution, right? They're proposing the problem. Is that right? So I think at that stage.
Right. It's fine. They're proposing the problem and what they would like to do. Here's the problem and here's what I think we could do. But developing really going through that whole incubation period, what that solution will look like at the very end is very different than at the very beginning.
Okay, and yeah, so the audience member says yes, that was the question. Okay, because it's the broad conceptual, like this is what we might do, which is not like intellectual property stealable thing.
Right.
Okay, I love your ideas over titles, and it sounds like that really, really, really worked for you.
Yes.
Ideas, so I'm going to steal that, I think.
That's okay. You can steal anything. And yes, we still have a lot of work to do, because I walked around the floor and I would say, okay, nursing assistant, did you put something in? Nursing student, did you put something in? The secretaries, please put something in. They're still watching everything. So we still need to help them a little bit more. We've learned a lot from this challenge. We just recently ended, the award ceremony was just December 17th.
Yeah.
So we've learned a lot. So we're really going to do some other work. But I can tell you, we involve leadership right from the beginning, and all 221 ideas will probably be put forward and worked on.
Wow. Is there ever anything that leadership says, no, we're not touching that?
Absolutely. And I'm sure there'll be one or two of those ideas, but as crazy as some of those ideas were that won't go forward, there is something to them. So if you meet with the staff and you can pivot, the problem was really done. The problem was really solid. It's just their solution, but that's what we're here for, is to help them incubate.
Yeah, so very cool. This is just so cool. I think, I liked your platform. What a great idea to be able to put it, have the problem, the solution anonymous. So like, it's a great way to disentangle. Oh, and now our time is up, because look who popped in. Philip popped into our room. So with that, Hiyam, thank you so much. I just have to say, I'm going to clap on behalf of the entire audience. This was just fabulous. You were fabulous. And now I'm going to turn myself off before Marion tells me to. And I'm going to hand this over to Marion.
Great. Thank you both. I hope you all enjoyed Hiyam's talk. I'm a big fan of her work and can't wait to watch the recording of her presentation. I'd now like to just recap our 3 presentations using the sketches created by the very talented Rachel Acker from Health Hero. So if somebody could pull up those sketches, please. So first up would be Kira Foley for In the Life, the LGBT app. Great. Second presentation was from Sophia Carreno with Food for Health.
Yeah, we're not, no, there you go.
The screen did not change for me, but I'm going to imagine it switched. And then finally, Jessica Abney and Julia Dunn with their Smart Swaddle. So I just want to say that you are all winners, and even if you don't get awarded today, please continue your work. It is incredibly important. Now I'd like to introduce Dr. Martine Sepulveda, one of our esteemed judges today and a member of the Penn Nursing Innovation Committee, who will announce the winners. Martine, are you good to come and do that?
Yes, am I audible?
You are audible, yes.
Okay, well, I want to echo Marion's comments on the extraordinary creativity and thoughtfulness, passion and commitment of the members of all of these 3 teams, and the support network that are helping them advance their initiatives. The judges were extremely impressed and valued each and every one of the three innovation concepts and ideas. And we concluded that we needed to recognize each of them with some amount of funding going forward. And the consensus of the judges was that Food for Health would, we recommended receive $10K, that In the Light receive $5K, and that Chrysalis receive $2.5K.
So congratulations to you all. You are all winners. We will, if you all want to come on video, please do, so we can give you a round of applause. Along with this funding comes entrance into our 10-month accelerator program. So we will work with you all to provide mentorship and education to help move your innovation idea forward. I'll be in touch in the next few weeks to go through all the details for that. But in the meantime, you should all celebrate your accomplishments and everything that you've done leading up to this point. Again, the judges and everybody were so very impressed. So thank you all for that. Before we close out, I just want to thank everyone who participated today and made this event possible, including Dean Tony, Dr. Terry Richmond, Dr. George Demiris, and Dr. Melissa Kelly, our speakers and judges, as well as my colleagues at Penn Nursing who helped make this event happen, our ITS department, events department, and marketing and communications. I'd also like to thank Thomas and Carolyn Bennett, Seth and Jane Gins, and Andrea Laporte, who helped fund this event. And finally, our participants for sharing their innovations. I hope they inspire more nurses to begin creating solutions to the problems they see in their own practice. Thank you all so much for attending, and have a good evening.
Thank you. Thank you, everyone.
Thank you, everyone. Congratulations.
Congratulations, everyone. Thank you.